Na sesji stomatologii SIMC 2023. Szanowni członkowie komisji, drodzy uczestnicy i słuchacze, szanowni państwo. W imieniu Zarządu Studenckiego Towarzystwa Naukowego Śląskiego Uniwersytetu Medycznego w Katowicach chciałabym serdecznie podziękować za przybycie i uczestnictwo w konferencji International Medical Congress of Silesia SIMC 2023. Nazywam się Karolina Ziaja i wraz z moim kolegą Filipem Moroniem mam przyjemność koordynować sesję stomatologii. Serdecznie witam komisję w składzie, jak już wiemy, pani przewodnicząca, doktor habilitowana nauk medycznych, pani prodziekan Małgorzata Skuchanowak i komisję w składzie. Pani doktor nauk medycznych Hanna Hybsz-Marzec, pani doktor nauk medycznych Daria Wziątek-Kuczmik, pan doktor nauk medycznych Lech Borkowski, pani doktor nauk medycznych Anna Jodłowska oraz pani doktor Agnieszka Balicz. W komisji online witamy serdecznie panią doktor nauk medycznych Magdalenę Wyszyńską.
Dzień dobry Państwu, witam.
Panią doktor nauk medycznych Olgę Michlewicz.
Dzień dobry.
Panią doktor nauk medycznych Ilczu Krypułę.
Dzień dobry.
Witamy również panią doktor Zuzannę Nowak oraz panią doktor Urszulę Rojek.
Dzień dobry Państwu.
Wszyscy są również w składzie jury, więc myślę, że możemy przejść dalej. Rozpocznijmy od kilku informacji organizacyjnych. Przede wszystkim tutaj ważna informacja zarówno dla jury, jak i uczestników. Kolejność prezentacji jest zgodna z kolejnością w książce abstraktów, żeby mieć to na uwadze przy ocenianiu prac. Każdy z uczestników we właściwej kolejności otrzyma możliwość udostępnienia prezentacji i tutaj my będziemy się tym zajmowali przy obsłudze technicznej. Czas przeznaczony na prezentację wynosi 7 minut oraz 3 minuty na dyskusję. W wypadku przekroczenia czasu uczestnik zobowiązany jest przejść do wniosków i jak najszybciej zakończyć czas prezentacji. Z uwagi na ograniczenia techniczne prosimy, by każdy z prelegentów samodzielnie pilnował czasu. Taka uwaga, my będziemy tutaj oczywiście z kolegą też czas nadzorować. Jednak prosimy, żeby w miarę możliwości tutaj zerkać. Jeżeli Państwo sobie życzą uczestnicy, my możemy dać znak, jeżeli przekroczymy 6 minut. W innym przypadku nie chcemy Państwu przeszkadzać w prezentacji, także proszę nam dać znać podczas podchodzenia, czy mamy taką informację sygnalizować.
I także kilka słów dla komisji. Jeżeli praca jest prezentowana w języku angielskim, pragnę przypomnieć, że dyskusja też musi zostać przeprowadzona w języku angielskim. W przypadku, gdy komisja zada pytanie w języku polskim, autorzy pracy są zobowiązani do udzielenia odpowiedzi w języku angielskim. W przypadku wprowadzenia dyskusji w języku polskim, dodatkowy punkt za język angielski nie zostanie naliczony. Dodatkowy punkt za język angielski każdy członek jury może przyznać tylko po zakończonej dyskusji, w której autor prezentujący pracę dyskutował po angielsku. W przeciwnym wypadku każdy członek jury przyznaje 0 punktów. No i tutaj mamy jeszcze kolejny punkt, w którym właśnie było powiedziane.
Tak, jeżeli dyskusja...
Dodatkowo.
Tak. Tak, czyli generalnie jeśli Państwo zadadzą komuś pytanie po polsku, to jeśli ta osoba chce mieć ten dodatkowy punkt za angielski, to musi też odpowiedzieć po angielsku, nawet jeśli pytanie było zadane po polsku. Także to już od Państwa zależy, czy pytania będą zadawane w języku polskim, czy w języku angielskim.
Tak. Ale w razie czego proszę się nie stresować, pytania można zadawać po polsku.
Tak, no i tutaj mamy właśnie jeszcze kolejny punkt, który mówi o tym, że można oceniać pracę z swojej własnej kliniki, ale tutaj rozumiem, że Państwo decydują się na tę opcję, że nie oceniamy takich prac, tak? Dobrze. No i teraz jak oceniamy pracę? Wiemy w końcu, czy jest punktacja od 1 do 5, czy od 1 do 6? Dobrze, czyli tak, w pierwszej kolejności oceniają Państwo wartość naukową danej pracy, następnie sposób prezentacji, potem to, w jaki sposób została przeprowadzona dyskusja. Można również ocenić pracę na podstawie jakichś swoich, na podstawie wkładu własnego osoby prezentującej. No i od 1 lub 0 punktów za to, czy była prezentacja w języku angielskim i dyskusja, czy nie.
Jeżeli chodzi o tą punktację w przypadku dyskusji w języku angielskim, my mamy w systemie takie okienko, także my będziemy to zaznaczali, żeby już Państwa dodatkowo nie obciążać. Także Państwo mogą się skupić jako jury na ocenie wartości merytorycznej i wszystkich tych 4 punktów, bo Państwo oczywiście tutaj są specjalistami w tej dziedzinie, a my będziemy tylko odklikiwać, czy prezentowana praca była w języku angielskim, czy w języku polskim.
Dobrze, no to myślę, że
Aha,
możemy już zaczynać.
Jeszcze jedna informacja również do komisji. Jeżeli sesja się zakończy, bardzo proszę, aby Państwo wypełnili te raporty właśnie takie w postaci naszych kart oceny i odesłali je z powrotem do nas w systemie. Tam prawdopodobnie jest guziczek, który Państwu to umożliwi. W przypadku jurorów, którzy znajdują się online, również Państwo powinni mieć dostęp poprzez link do karty oceny i również prosimy o odesłanie do koordynatora.
Ale to dopiero na samym końcu, tak?
Tak, na samym końcu. Na samym końcu, bo rozumiem, że Państwo widzą aktualnie jedną kartę oceny.
Tak, wszystkie karty, wszystkie możemy robić.
Aha, wszystkich prac,
Tak.
dobra. To myślę, że jak Państwo zaznaczą, to już będzie przesłane.
Tak, część nastawić dobrze.
Dobrze, no to myślę, że my to rozwiążemy jakoś w systemie później, bo my mamy wyglądy do Państwa ocen, także
No jak chcecie, możemy równocześnie będziemy na kartkach wam też pisać, w kartach głosowania, zróbmy na początku.
jeżeli dla Państwa to nie będzie problem, żeby równocześnie pisać w papierowych kartach, to możemy takie rozdać.
Pracy,
Dobrze, dobrze, dobrze. Dobra, możemy tak zrobić, oczywiście.
Aha,
No i będzie to miało
ale czekajcie, ale czy zero nie
Same
jest mniejszy?
Ale jedynka nie ma zera.
A, nie ma zera, jest jeden.
Jedynka to też może być ocena, ale
No
chyba nie
właśnie.
będzie.
To mogą w takim razie po prostu Państwo ewentualnie też na kartach wypełniać. Dobra, to już rozdajemy, już rozdajemy.
A, my nie mamy.
Nas też tutaj rzucono na głęboką wodę, także dla komisji, która znajduje się online, jeszcze taka jedna informacja, że rozdajemy papierowe karty jurorom obecnym na miejscu, ze względu na to, że mamy taki mały test systemu, a tutaj komisja podjęła jednogłośnie decyzję o tym, aby nie oceniać prac ze swojej katedry, niezależnie od tego, czy jesteśmy opiekunem koła bądź pracy. Decyzja została jednogłośnie podjęta, że nie oceniamy pracy własnej katedry.
Jednostki.
Zgadza się, z własnej jednostki. Rozdajemy karty i zaraz przechodzimy już do głównej części naszego spotkania. Już rozdajemy Państwu długopisy.
Tutaj numer pracy. Zielony, tak? No, jedynka. No nic, to sobie sami zaniesiemy numer pracy. Macie dobrze? Ja mam sobie sama nanieść numer pracy, tak? Bo tu jest od 17, czy to pomyłka? Nie macie.
Drugą stronę dostała.
No, ale
Nie. Aha, czyli my tu swoje dane wpisujemy, tak?
jak nie macie, to ja tam naniosę. Dajcie, ja to napiszę. Nie, to mam napisać.
Dobrze, w takim razie zapraszamy autora pierwszej pracy Stress Related to Tooth Extraction autorstwa Wojciecha Niemczyka. Wielkie brawa dla naszego pierwszego uczestnika.
Gdzie mam stanąć, żeby... Ja mam jakiś pilot zmiany slajdu, czy... Okej, dobrze. No, nie będzie. Okay. Honorable jury, ladies and gentlemen, my name is Wojciech Niemczyk, and I'm a dental student from Silesian Medical University. Together with Dr. Agnieszka Balic and Dr. habilitowany Tadeusz Morawiec from Chair and Department of Dental Surgery, along with Dr. Karolina Lau and Dr. habilitowany Janusz Kasperczyk from Chair and Department of Environmental Medicine and Epidemiology, we have research on the problem of stress that is related to tooth extraction. But it would be appropriate to start with a few words about stress. Well, stress is usually described as sympathetic nervous system's reaction to a negative stimuli, and those stimuli can be both physical and psychological. In other studies, it was noted that more than 40% of patients have from mild to severe dental anxiety. For clinicians, it is important because the psycho-emotional status of the patient is strongly associated with patient-doctor comfort during the procedure. The topic of this research was chosen because of the fact that tooth extraction is most common surgical procedure in dental surgery. Not only it's most common among all of the age groups, but also, in previous studies, dental surgical procedures were described as the most stress-provoking out of the list of 67 procedures. Moreover, third molar extraction were at the very top of the list. Next. But what was exactly the aim of our study? The aim of our study was to analyze factors influencing both pre- and post-extraction stress. So when it comes to material methods, we conducted a survey consisting of 30 questions, 13 of which were from standardized belief about pain control questionnaire, BPCQ, among 250 patients. Some of the questions were asked before the procedure and some just after. Stress was measured using a 10-point visual and analog scale. Out of 250 patients, 150 were female and 100 were male, at the mean age of 29.4 plus minus 13 years old. Of these patients, 50 had extraction of fully erupted teeth and 200 had dermectomy or extraction of fully or partially retained teeth. All of the patients were admitted to Academic Center of Stomatology in Bytom. During data collection, we also divided patients into 7 groups based on 4 criteria and their combinations. These criteria were pain, history of extractions, tooth retention, and oral sonation. Out of the results, average level of stress before procedure was 5.21, but women had presented over 30% higher level of stress compared to men. For comparison, average level of stress after the procedure was 3.22, and women had almost 50% higher level of stress after the extraction compared to men. Another result was noted between patients with a different level of tooth eruption. Despite almost 2.2 times higher level of preoperative pain in patients with a fully erupted teeth, the average level of preoperative stress was 21% lower in the same group. In order to analyze stress factors, we also divided patients into 2 groups, with and without history of extractions. Patients with a history of extractions were characterized by lower level of perioperative stress, which was represented by 14% lower preoperative stress and over 30% lower postoperative stress. When asked about most stressful factor, patients most often indicated the fear of complications after the procedure at level of almost 40%, while least stressful factor was fear of anesthesia at level of 16%. It's worth to notice that both of these factors were reported at a similar level by both of these groups. The situation is different for other stressors because patients who had never had extraction were over 56% more likely to indicate the fear of the procedure itself as strongest stressor, while patients with a history of extractions were almost 46% more likely to indicate the fear of postoperative pain as strongest stressor. When it comes to results of BPCQ, women were characterized by 1.5 points lower level of internal factors or average, which may suggest that higher awareness of patients' contribution to the pain control reduces the stress level. But when it comes to the main conclusion, perioperative stress is in fact strongly dependent on the numerous factors, of which strongest contributors are gender, history of extractions, and level of tooth eruption. It's worth to remember that although patient's level of stress is decreasing after the procedure, it still remains at a relatively high level. And some of the informations like postoperative instructions or even assurance of successful procedure might be misunderstood. This is why it is so important to provide a comprehensive postoperative care in our patients. Thank you for your attention, and now I'm ready to answer your questions.
Bardzo dziękuję za piękną prezentację i chciałam zapytać, jak odniósłby się Pan do tego wyniku mówiącego o tym, że wyższy poziom stresu był u kobiet zauważony?
Well, at first we have to know what stress is and what consists of the stress. Well, as I said, stress is a sympathetic nervous system's reaction to a negative stimuli, and the stimuli can be both physical and psychological. Those stimuli physical, it's pain sensitivity. And as we know, women are most sensitive to some stressors or factors like for example, pain. And the other component was the psychological element. And in other studies, it was shown that the area responsible for analyzing things is more active in women's brain. So with those two components, it may make that women are more stressed than men. If I answer your question, I think.
Czyli Państwo uważacie, że kobiety jako osoby bardziej wrażliwe, bardziej na ten stres reagują, bo mężczyźni od razu mdleją i stresu nie mają, rozumiemy. Bo to jest moje doświadczenie z gabinetu w okresie 20 kilku lat. Dobrze, bardzo dziękuję. Czy ktoś jeszcze?
Maybe the problem is in the method of the study, of your study, with the method of analysis. It's quite different than our life, in our observation.
Maybe, but I think that methods are quite very well executed in this study, because if we look at other studies, the stress is measured in hypothetical situations or maybe retrospectively, because maybe in these studies there are things like, imagine if you had extraction, what is your stress level? But our study was really accurate in that point, because we measured the stress directly before the extraction and directly after the extraction. So it's as accurate as it can be.
Dobrze, bardzo dziękujemy.
Thank you.
Czy są jeszcze jakieś dodatkowe pytania od komisji online lub po komisji obecnej na żywo? Okay, so thank you very much for your presentation. Dobrze, i teraz przejdziemy sobie do kolejnej prezentacji.
Tylko my możemy teraz głosować, tak?
Tak, teraz mogą Państwo głosować w systemie.
Przepraszam jeszcze, nie wiem jak reszta komisji, ale my nie widzieliśmy prezentacji. Też.
Tak. Chciałam właśnie o tym wspomnieć również, że prezentacja nam się nie pokazywała.
Ojej, bo tutaj udostępniliśmy Państwu prezentację.
Prezentacja inaczej, był zatrzymany
Jeden
slajd
slajd.
jeden. No, nie przesuwała się.
Okej, dobra, w takim razie. Dobrze, to myślę, że tą sytuację możemy rozwiązać w taki sposób, żeby tutaj nasz pierwszy uczestnik nie był stratny oraz komisja. Czy uczestnik wyraża zgodę, żebyśmy przesłali komisji online prezentację do wglądu? Super, świetnie. Bardzo przepraszamy za problemy techniczne. Tutaj prezentacja była udostępniona, także nie wiemy, co tutaj się...
Czy teraz widzą Państwo prezentację i czy zmieniają się slajdy?
Widzimy. Tak, teraz się zmienia.
Dobrze, to w takim razie już zaraz do Państwa przesyłamy prezentację pierwszego uczestnika i prosimy o sekundkę cierpliwości. Czy prezentacja jest widoczna dla jury online?
Tak.
Dobrze, i czy zmieniają się slajdy?
Tak.
Świetnie. W takim razie zapraszamy na scenę autorów drugiej pracy, Multidisciplinary Approach to Enhancing the Welfare of Patients in Maxillofacial Surgery, Katarzyna Janik, Antoni Świątkowski, Małgorzata Rymarczyk and Zuzanna Galicka. The floor is yours.
Good morning to all attendees, dear committee. My name is Katarzyna Janik, and today I have the pleasure to deliberate with you about a multidisciplinary approach as a key to success in enhancing the welfare of patients in maxillofacial surgery. The head and neck region is a highly specific area where the digestive system, along with the nervous, respiratory, and musculoskeletal systems meet. This fact has implications in terms of every surgical intervention, which can lead to a range of dysfunctions, not only interfering with the function, but also highly visible, affecting the aesthetics and thus the patient's mental state. They include difficulties with pronunciation, cicatrix, recurrent edema, etc. The aim of the study is to present the effectiveness of multidisciplinary rehabilitation as a key to success in enhancing the welfare of patients in maxillofacial surgery. This study was carried out in the Department of Craniomaxillofacial Surgery in Katowice in the years 2020 to 2022. It included 132 patients aged between 18 and 85. More than half of them were women. They were divided into 4 groups, the most numerous one post-traumatic patients, oncological, patients after orthognathic surgeries, and others. The clinical rehabilitation team responsible for the whole project was created mainly by us, students, who work with the patients under the guidance of doctors and physiotherapists. The appointments were scheduled each week. What techniques have we been using? Dry needling, mobilization of the temporomandibular joints, lymphatic drainage are some of them. Moreover, we educated patients about the autotherapy methods that they could use at home, as well as about how important is maintaining a balanced diet specific for their condition. The dysfunctions of facial nerve were observed in 15% of the patients in the study. After the rehabilitation, among 75% of them, a full function of facial nerve was recovered. The treatment was regularly evaluated using Sunnybrook facial grading system. Both of the patients shown here were treated surgically for the condylar fractures. The initial Sunnybrook scores were 58 and 25 respectively. After the 4 months of rehabilitation, both of the patients managed to achieve a full range of the facial nerve function, which was 100, which was score 100 in the Sunnybrook scale. The disorders of mandible abduction were noted among 75% of the cases, and 69% out of them managed to achieve a full range of abduction. On the left side, we can see the results of the rehabilitation during one appointment where the abduction range enlarged from 19 millimeters to 36 millimeters. In the middle part, we can see the results of 4-week therapy, where the range of the abduction increased from 12 to 43 millimeters, which is a correct range of values. The last patient, oncological patient, was treated for buccal mucosa cancer. In that case, a full range of abduction was not achieved, but the patient reported a greatly improved tissue mobility, scar aesthetics, and symmetry of the lips. It is common among oncological patients that they report the enhancement, even though the rehabilitant is often not really able to measure the results of the therapy objectively. Moving on to the most common dysfunction among our patients, the reduction of aesthetics occurred in 96% of the cases, and 80% of them resulted in subjective improvement of aesthetics. Let's have a look at the patient after multi-fracture of the middle part of the face with tooth loss, deep and extensive cicatrix. After 6 months of the therapy, we could observe better symmetry of the lips as well as flattening of the cicatrix. The second case is a patient after mandible cancer with lymphatic dissection and pectoral flap reconstruction. After removal of the tracheotomy tube and percutaneous endoscopic gastrostomy tube, a comfortable oral nutrition was possible. Moreover, the initial muscle pain and contractures of the upper quadrant were minimized, along with the subjective improvement of aesthetics. Summarizing, what we need to keep in mind is that the treatment of the disease is not equal to the treatment of the patient. It is extremely important to focus not only on the surgical intervention, but also on the rehabilitation and the maximum possible recovery and comfort of everyday life. 3 observations of the clinical rehabilitation team illustrate that providing multidisciplinary treatment of patients suffering from the diseases in the craniomaxillofacial region is successful in reducing the risk of permanent post-operative complications. Nevertheless, such procedures are not yet a standard practice in this field. Further studies are crucial for creating harmonized algorithms and guidelines for the post-operative management of patients in craniomaxillofacial surgery. Thank you for your attention.
Thank you very much. And now I would like to invite you to the discussion part. Have you got any questions? Tylko poproszę do mikrofonu, żeby komisja też online słyszała.
Ja mam pytanie. Halo, halo, czy wszyscy mnie słyszą?
Tak.
Ja mam pytanie o wkład własny.
As I already have mentioned, the clinical rehabilitation team that was working with the patients was created mainly by students. We had appointments each week on Saturdays where we spent a couple of hours working with the patients under the guidance of doctors and physiotherapists. We also measured the results of the therapy in the documentation as well as on the photographs.
Dziękuję.
Thank you for the question.
Jeszcze pytanie. Na jednym ze zdjęć były elementy akupunktury. Czy ja źle widziałam?
On this picture, a technique called dry needling was used. It is
akupunktura.
It is used in the therapy of cicatrix in order to improve the aesthetics, improve tissue mobility, and to flatten the range of the cicatrix.
A kto to wykonywał? Państwo czy?
We did this method.
A macie jakieś przeszkolenie tym aspekcie?
Yes. The doctors as well as the physiotherapists were showing us how to perform this technique, and were all the time by our side. So every our intervention was under control.
Okej.
Jeszcze krótkie pytanie. Jeszcze raz dziękuję za piękną prezentację i chciałam zapytać, jak wyglądała współpraca z pacjentami? Czy chętnie współpracowali? I spektakularna poprawa jest widoczna, bo 80% po 6 miesiącach, tak? Nie wiem, czy dobrze zrozumiałam. I chciałam zapytać, czy ta poprawa była taka linijna, stopniowa, czy jednak były takie okresy, kiedy nic się nie działo, kiedy nie zauważaliście Państwo poprawy?
The duration of 6 months was, in the case of the first patient of this slide, the duration of rehabilitation really varied. Post-traumatic patients usually had a shorter time of rehabilitation, from 1 month to a couple of months, for example, 6 months as here. In contrast to the oncological patients whose rehabilitation was usually during the whole time of the project, because oncological patients often after lymphatic dissection need the therapy to the end of their lives because of the recurrent edema or problems with the aesthetics or such crucial functions as swallowing or speaking, because oncological patients after the dissection of so many tissues often have to learn like for the first time how to speak, how to eat, or how to make facial expressions. So it's a really new beginning for them, I would say.
You. Does the online jury have any other questions?
I was going to ask, did you mobilize your patients right away after the surgery, or was there any period of time when when the movement in the temporomandibular joint was stopped, was blocked?
Usually we started the rehabilitation as early as possible. Some of the patients started right after the surgery, some of them because of the different because of individual state started the rehabilitation a couple of weeks later, but usually not longer than 2 months. The reason for this, for example, were the not really good both mental and physical state after the surgery. So we started the therapy as early as possible so they felt comfortable with it.
Yeah, I understand. Perfect.
Thank you.
Okay, are there any other questions? Okay, so thank you very much for your presentation. Thank you for the questions. Second, please. Okay, so now we can start the third paper entitled Tongue Temperature Distribution as a Prognostic Method in the Diagnosis of General Medicine Conditions by Adrian Gąsiorek, Aleksandra Mrowiec, Kamila Wolnica, and Antoni Świątkowski.
Good morning to all attendees, dear committee. My name is Adrian Gąsiorek. I'm a third-year dentistry student and I represent the student research group of the Department of Craniomaxillofacial Surgery of Medical University of Silesia. I would like to talk to you about the research we've been doing together with the student research group of Faculty of Science and Technology of University of Silesia. The relationship between body temperature and diseases dates back to the old days of medicine. In the diagnosis of many diseases, where temperature may indicate the presence of inflammation or where blood flow is increased or decreased, temperature assessment is crucial. The tongue diagnosis might be a very useful method for identifying general disorders. It originates from Chinese medicine and may quickly indicate issues with organs which are connected to the tongue. In our research, we decided to combine two things, tradition and technology. That is why we used thermography to examine tongues. We believe that the older approach deserves more attention. The perfect healthy tongue should be light red or pink in color and have a thin white coating. Any deviation from that may be a clue that something is wrong. The tongue is a map of our body. A lot of us may not realize how much the condition of our tongue represents our general health. Have you ever noticed when you had a cold or a flu that you have a thick white coating on your tongue? It always changes to represent what's happening inside your body. Each part of the tongue actually represents a different organ system. From recent research, we learn that the tongue can be used in screening to diagnose conditions such as coronary artery disease, diabetes, and anemia, as there are significant temperature deviations compared to healthy individuals. Thermography is a medical imaging method which uses thermography is a medical imaging method which uses infrared cameras to record an object's or area's temperature. It's commonly used in medicine to identify inflammation and other abnormalities in our body. Unlike X-rays or CT scans, thermography is perfectly safe and may be used for those who wear metal implants or, for example, pregnant women. This preliminary study investigated the potential of the diagnosis of general disorders when we look at the correlation of temperature distribution on the tongue. The outpatient clinic for maxillofacial surgery of our university in Katowice, patients at high risk of systemic infections were screened for correlation of tongue temperature with underlying conditions. The patients from the research group came from various departments: oncology, hematology, ophthalmology, cardiology, and there are also patients qualified for transplantation. This study involved 41 patients, each with a different medical condition. A control group of healthy individuals was also involved. In this study, the FIR T540 camera was utilized as a high-performance thermal imaging camera. Its exceptional thermal sensitivity, which measures in less than 0.03 Kelvin at 30 degrees Celsius, was a standout feature, enabling everything to detect even the slightest temperature deviations. Each patient was clinically examined, acclimatized to the room temperature, and then intraoral photographs were taken, with the open mouth positioning the center of the study area. The participants were asked to keep their tongue in a relaxed, rested position, and then, after 2 and 10 minutes, the photographs were taken. The thermal imaging camera was set perpendicular to the patient according to the standards of thermal imaging in medicine. Now, moving on to the examples, these thermograms show a patient who suffers from neuroborreliosis and also from choroidal inflammation. As you can see, after 2 and 10 minutes, the temperature distribution is very asymmetrical. And also at the tip of the tongue, The tip of the tongue got actually cooled down by 0.6 degrees Celsius. Next, we have a patient who's perfectly healthy. As you can see, after 2 and 10 minutes, the temperature distribution is almost perfectly symmetrical. And also, the tip of the tongue got heated up after 10 minutes by about 2.3 degrees Celsius. The obtained thermal images were analyzed and compared between the groups. Statistical analysis was performed using STATISTICA-10 program. Man-Whitney U-test was used for non-normally distributed or non-homogeneous data, while t-test was used for normally distributed data. Significant difference was observed in mean temperature values of specific area of the tongue surface between the ophthalmic patients and healthy individuals, with a p-value of 0.01, indicating high confidence in the results. The study showed higher mean temperatures in patients with ophthalmic conditions compared to a control group that included patients with other medical conditions. Ophthalmic patients were long-term patients who suffered from conditions such as inflammatory glaucoma, uveitis, or optic atrophy. The findings of our preliminary study demonstrate a notable and statistically significant difference in the distribution of tongue temperature between individuals with general conditions and a control group. Furthermore, the study highlights that this difference was also evident after 2 and 10 minutes of image registration within the patient. For further clinical usage, we need to do more research. For further clinical utilization, we need to do more research about the subject. Thank you very much for your attention, and you're now more than welcome to ask any questions.
Does the jury have any questions?
Mam pytanie, skąd pomysł na takie ciekawe badania?
Well, as you could probably see last year at SIMC, we already presented thermography, but we used it for something else, for tooth-related infections. And then we just looked at the research on the internet, actually, and then we noticed that we could be the pioneers of using thermography to identify general disorders. And after learning about our results, we were very happy to discover that we might actually be onto something.
Okay, thank you.
Does online jury have any questions?
Ja chciałam powiedzieć coś. Nie wiem, czy mnie słychać dobrze?
Yes, yes.
Chciałam powiedzieć, że bardzo fajny pomysł w mojej ocenie na badania. Tak się zastanawiam, może ciekawe byłoby również wykorzystanie tej metody i zbadanie pacjentów protetycznych z tak szeroką, że tak powiem, objawami występującymi stomatopatii protetycznych, których mamy. Także sobie myślę, że tutaj też warto by było może taką grupę pacjentów stworzyć. Nie wiem, czy Państwo kwalifikowaliście, jak z kryteriami włączenia, jakich pacjentów tutaj rozumiem, że bez stanu zapalnego miejscowego w jamie ustnej. Dziękuję.
Well, it's a pilot study, so we were just starting, but definitely we are planning on including basically everything to investigate the potential of this method. And prosthodontics sounds like a great idea of one of the utilities of this method.
Dziękuję bardzo.
Are there any other questions? Okay. We have a question from our participant.
Gratuluję prezentacji. Mam pytanie, jak wyglądało przygotowanie pacjentów do tego badania? Czy ta metoda wymaga jakiegoś specjalnego przygotowania? Dziękuję.
Okay, 1 second.
Yes, as a matter of fact, the patients were supposed to rinse their mouth for 1 minute with a cup of water so that we could see the differences of the tissue heating up after 2 and 10 minutes. It was one of the factors that we looked at.
Thank you very much for your presentation. And now I would like to invite the fourth presentation authors, which is Paulina Musiał, Magdalena Błasiak, Małgorzata Imiołczyk, Aleksandra Grzyb, Dawid Hochuł.
Ja coś mam ciągle, on gaśnie i koniec, to się nie da nic zrobić.
Okay, so the floor is yours.
Good morning, ladies and gentlemen, dear jury, dear fellow participants. My name is Paulina Musiał, and on behalf of my colleagues from the research group of the Department of Orthodontics, I am pleased to present our Sorry. First of all, I'd like to thank our work tutors for their helpful insights and the opportunity to work under their supervision. So the title of our presentation is Dental Age Estimation in Silesian Children with the Emergence Method. Different methods have been developed to estimate age. These include using bone age, morphological age, and dental age. Dental age estimation focuses on establishing one's individual age by assessment of tooth development, which is seen on the radiographic pictures. The emergence method is just one of many methods to estimate dental age in children and adolescents, and it was published by the Emergence and co-workers in 1973. The study was conducted on a large group of French-Canadian children of the Caucasian race. It is based on evaluating 7 permanent teeth from the left side of the left quadrant of the mandible, from the beginning of mineralization to the closure of the apex. Since that time, numerous studies on this issue have been conducted for other populations, showing a great variability in the dental maturation process. However, there's no enough data concerning children of the Silesian region. Therefore, we wanted to see whether the emergence method could be applied in this particular group of children to assess the dental age. The emergence method describes 8 stages of tooth calcification, ranging from A to H, where stage 0 means that there is no tooth calcification seen on the radiographic picture. The scoring system of this method is also differentiated between girls and boys. For this study, we used 120 orthopantomograms of Silesian children aged between 6 and 12 years who were treated at the Department of Orthodontics of the Medical University of Silesia. Out of those 120 orthopantomograms, we rejected 60 due to different reasons. The exclusion criteria included additional teeth, transpositions, transmigrations of teeth, the absence of tooth germs, and any kind of disease that could affect the general growth and development of the child. The qualified 60 OPGs were later divided into 2 equal groups of 30 boys and 30 girls. The dental age was calculated by assessing teeth from central incisor to the second molar of the left quadrant of the mandible. According to the emergence, the appropriate stage from A to H was assigned for each tooth. The stages were different from single as well as multi-root teeth. Each stage was assigned a specific value, which has been found in the emergence standard tables. The assigned values made a sum for each patient separately, and that value enabled reading the dental age from the emergence central grids and tables. The chronological age of the patients, on the other hand, was determined by calculating the difference between the orthopantomography examination and the date of birth. The patient's age, presented in years and months, so the metrical age, was converted into decimal numbers to preserve the appropriate unit for the calculation. The converted patient's age was then subtracted for the emergence method, and the difference was calculated on this basis, which later indicated delays or accelerations. The results are presented in 2 tables as follows. The first table shows the average age in both study groups. It refers to chronological age, dental age, and the deviation of dental age from the chronological age. The second table presents a comparison of the chronological and dental age of children who were examined. It shows the percentage of dental age acceleration or delay in both girls and boys groups respectively. The trend of accelerated dental age in both groups is evident. Moreover, the percentage of girls with accelerated dental age is relatively higher than boys. None of the cases show that the dental and chronological age was equal. The main group of girls, collected data, the next one. Collected data are presented in two graphs for girls and boys, showing the differences between average dental age and average chronological age. The main group of girls was divided into 3 age subgroups, according to chronological age. The first group refers to the children between age 6 and 8, the second one from 8 to 10, and the third one above 10, so from 10 to 12 years old. The first two subgroups present a visible dental age acceleration, whereas the third group presents a higher difference, but the opposite tendency, the dental age delay. Analogously, the same thing has been done with the group of boys. The group was divided into 3 age subgroups. The graph illustrates the same tendency for boys as for girls. So in first two subgroups, we see that the dental age was accelerated, and the third group, the dental age was delayed. According to collected data, the following conclusions could be drawn. The differences between chronological and dental age in both girls and boys groups exists. The biological maturity of children between 6 and 10 years of age, expressed by dental age, was higher than chronological age. For children between 10 and 12 years of age, the opposite trend was observed, with dental age being delayed. None of the cases showed that the chronological and dental age was equal. And for comparative and diagnostic purposes, this method, the affirmation method, should be updated for each population. And just the final words, the emergence method might be simple, fast, and easy to apply. However, other methods should be taken under consideration while assessing the dental age in Silesian children. It shows the necessity to create a representative database for each population in order to reach a better comprehension of human dental maturation. Thank you very much.
Are there any questions for the participant?
Bardzo dziękuję za prezentację. Z Pani tutaj prezentacji wynika, że metoda znajduje zastosowanie w ortodoncji. Czy widzicie Państwo jako autorzy możliwość zastosowania tej metody w jakichś innych dziedzinach stomatologii, w innych specjalizacjach?
Yes, definitely. So besides orthodontics and pediatric dentistry, to really indicate the right time to start the treatment, it is also used in forensic medicine, forensic science, in various situations. For example, when there's an unidentified diseased body of a child, to really assess the age. Also in refugees who are seeking asylum and they don't have any birth certificates, or there's no proof or identity. Also in medical legal cases, including minors, to really guide the authorities where to put this individual into prison or into an institution for adolescents. And also in anthropology, archaeology as well. So that's why it's so interesting that it can be used in various fields of medicine.
Are there any other questions from the online jury?
Chciałam zadać pytanie poza. Ja mam pytanie takie, które nie chciałabym, żeby miało wpływ na ocenę, dlatego że widziałam tutaj bogatą bibliografię, a metoda Demidżana jest już też uznana dość. Czy w związku z przygotowywaniem do pracy Państwo, czytając piśmiennictwo, natknęli się na jakąkolwiek ocenę dotyczącą wątpliwości diagnostycznych związanych z tym, że zdjęcie panoramiczne jest zdjęciem warstwowym? Czy kiedykolwiek padło coś takiego? Ja zawsze mam wątpliwości i sama to potwierdziłam i wiele takich prac dotyczących, ja się zajmuję taką sytuacją, gdzie badam rozwój zębów. Absolutnie nie można opierać swojej oceny rozwoju na zdjęciu warstwowym. Ale czy Państwo, tak jak mówię, nie chciałabym, żeby to miało wpływ na ocenę, bo to jest dość zaawansowane, ale czy tam takie na przykład w jakimś rozdziale limitations, czy takie jakieś padają? Dziwne pytanie, bo metoda jest bardzo uznana, bardzo. I głównie się to ja dziękuję.
Jest to przede wszystkim o tyle uznana metoda, że zdjęcia pantomograficzne mogą stanowić etap zdjęć przesiewowych, dostępnych dla bardzo dużej grupy pacjentów, więc w całej swojej masie stanowią później, że tak powiem, bardzo dużą wartość badawczą i diagnostyczną. Nie każdy pacjent ma możliwość wykonania tomografii. Także wydaje mi się, że pod tym kątem, ale tak samo właśnie zwracam się, czy z czymś takim Państwo żeście się spotkali.
Thank you for pointing this out. That's really crucial. But from what I remember, honestly, there wasn't any kind of information regarding this issue. However, yes, that should be taken under consideration as well.
Thank you very much. Are there any other questions? Okay, if not, thank you very much for your presentation.
Przepraszam, my nie słyszymy chyba.
No, przepraszam bardzo. Czy słyszą mnie Państwo?
Tak, teraz lepiej.
So the aim of our study was to assess how well the Polish doctors knew about new technological advancements, as well as how readily they use these in their daily practice. Our method consisted of qualitative data, which we obtained from an anonymous questionnaire, which we sent to social media groups containing dentists from Poland. Direct requests were also sent to academic teachers, as well as other dentists that we knew. We analyzed technologies such as laser and more new technologies such as computer-assisted local anesthesia, intraoral scanners, cone beam computed tomography, microscopes, radiography devices, as well as the endometer, which is an already well-established technology. We wanted to see how well this implementation has gone in retrospect. Why did we choose technology? Why is it important? We asked dentists why technology is important. The main reason cited was to increase the number of patients, improve the quality of treatment, the ergonomics for the doctor, improving the quality and efficiency of treatment, better patient experience through faster treatment, less time on the dental chair, as well as a more accurate diagnostic methods, particularly useful in fields like endodontics. Next, please. This is our questionnaire. Initially we asked biometric data, including gender, age, years of practice, workplace. We also asked questions such as which technologies they were interested in, which technologies they were acquainted with during their studies, which technologies they use on a daily basis, which technologies do they own, which they apply, as well as we sought open justification in questions such as why does investing in new technologies bring any advantages, and as well as the development of technology, whether it had an positive impact on the dentistry in general. 70% of the respondents were women, which is in line with the general population of dentists. The most prominent age group was between 30 and 39 years. So people who work less than 10 years. In general, 6 to 9 to 10 years was the main years of experience in the group of 150 dentists. 52% were general dentists, 37% specialized, and overwhelming majority, 55%, worked in the private sector. Only 9% worked in the public sector alone. The rest in both. The place of work was mainly a city with over 100,000 inhabitants, and half of the dentists owned their own practices. Most people were familiar with a digital X-ray, dental microscope. Surprisingly, 7 dentists weren't familiar with the endometer. We concluded that this must have been because of these were older dentists. We saw that some dentists were over 80 years of age. Dental lasers were the least popular. The endometer was also the most popular when it comes to being acquainted with these during their dental studies. Dental lasers were least popular. The digital X-ray, dental microscope, again, at the top. Methods of continuing education, 93% use technology in their practice. The levels of interest in developing new technologies as well as implementing them in practice was judged to be very high. 69% of respondents agreed with this. Moderate interest was declared by 24% of the respondents. Conferences and trainings in the country were the most popular. And as well as internet and friends of dentists, these were the most popular methods of attaining new information. The endometer, digital X-ray, and the dental microscope were again the most popular methods, most popular technologies used on a daily basis. Again, the endometer was used as a means of attaining this retrospectively. Why was it important to invest in new technologies? Most dentists cited for increasing the quality of treatment. Attracting more patients was the least popular reason. And of course, improving patient comfort came second. When asked about the real benefits, only 2 out of the 150 dentists which we asked said there weren't any real benefits. When asked to justify this reason, they cited increased accuracy and comfort of work, greater patient satisfaction, faster and more effective treatment, as well as a lower risk of failure and complications, especially endodontists will agree. Patient interest was also judged to be very high. 92% of respondents said they saw significant patient interest, while only 12 said this wasn't the case. So our conclusions were that the most popular technologies, unsurprisingly, were dental X-rays, dental microscopes, and endometers. These are all quite widespread technologies, and few of the new technologies were actually implemented widely. The willingness to implement technology as well as interest in technology did not depend on the biometric factors that we asked about in the survey. Interest was extremely high in all age groups. The knowledge was mainly gained through conferences in the country, perhaps because of the ease of learning in one's language. Investing in new technologies brings real benefits, such as increasing the accuracy of work and increasing satisfaction with treatment, according to the dentists we surveyed. And next, please. Thank you very much.
Thank you very much. Are there any questions from the jury?
Ja pytania zadać nie mogę, bo to jest z mojej jednostki. Proszę się na mnie nie patrzeć.
Ja chciałam zadać Państwu takie pytanie, to były badania ankietowe. Ankiety przeprowadzaliście u tych 150
Yes, so we sent a online form on Microsoft Teams to 150 dentists. So
w jakim czasie?
We conducted this over 3 months at the start of this year.
Thank you.
I got one more question. Have you noticed significant difference between dentists working in quite big agglomeration and small countries, small towns?
Surprisingly, no. We looked at these biometric indicators. We did basic statistical tests on this, and we found that there was no difference in whether the place of work was a village, etc. Our results also
about the willingness of the dentists, or just the access to the new technologies?
The willingness. The willingness
Okay.
was declared. It was very high in every single practice. Our results did show quite widespread technologies such as the endometer, X-ray, microscope, to be the clear winners, but of course this is also quite widespread and common even in private practices in villages. So we did not see any significant difference.
Okay, thank you very much.
If I could say something, I was wondering, because in the title, in the introduction, you're putting the stress on the modern technologies. And then I was wondering, does including endometers and X-rays, doesn't it introduce quite high bias into the work? Because one of the conclusions was that the interest was very high, but the endometers and X-rays are really popular. It's not that modern. So that part, at least, of the conclusion seems to be quite biased.
Yes, we also identified this. As I mentioned previously, the endometer was used to ascertain how this process went retrospectively. So the endometer, of course, as of course you mentioned, is a widespread technology as well as the dental X-ray. However, we did want to see how this fared in the past. So of course we did include new technologies, but we also tried to include these technologies to pinpoint how these dentists implemented these in the past, to give us some information on how this could develop in the future, if that makes sense.
Okay, thank you. I was thinking in that case maybe to dividing it into two groups analyzed as well. But thank you very much.
Thank you.
Are there any other questions? Okay, so thank you very much for your presentation. And now I would like to invite the authors of the sixth presentation entitled Evaluation of the Effect of Covering the External Carotid Artery on Craniofacial Pain, a Preliminary Study.
So good morning, ladies and gentlemen. My name is Emila Senderek, and I am the 6th-year medicine student. And today I'm representing the Department of General Surgery, Vascular Surgery, Angiology, and Phlebology here in Katowice. We would like to introduce you to our preliminary study that is an evaluation of the effect of covering the external carotid artery on craniofacial pain. Why did we came up with this idea? So while the sources of pain, the craniofacial pain can be different, but the vascular nature of the pain is not always taken into the consideration while performing an differential diagnosis. So that's why we came up with this idea. Currently, some publications indicate that covering of external carotid artery, the occlusion of it, can lead to the craniofacial pain. So we can move on. I'd like to start with a short explanation of the procedure I'm talking about right now. So here we have a scheme with the carotid arteries mainly, because we're gonna focus on them. Next one. Yes, okay. So here we can see a stenotic internal carotid artery with abnormal blood flow within it. Later on, a special stent and a balloon are inserted within the external carotid artery to improve the blood flow. Next one. And this method almost always leads to the complete coverage of the external carotid artery, which is the main source of vascularity for the craniofacial part of the skull. Next one. For better understanding, I thought maybe it would be a good example to give an angiogram, intraoperative one. As I said before, the external carotid artery in the after picture is completely covered by the stent. The aim of our study was to evaluate the effect of external carotid artery coverage on the perioperative and early post-operative craniofacial pain. Our methods. The prospective study was conducted in a group of 26 patients. 26 patients. All of them were treated for the critical critical stenosis of internal carotid artery, and all of the procedures were performed in a typical way using neuroprotection. And immediately in 24 hours after the procedure, the patient were asked to provide some subjective information expressed in a visual analog scale regarding pain and its location. Yes, we can move on. Here is the typical set used for this procedure. On the left is a neuroprotection device, and here we can see a stent on the right. Next one. Here are some general aspects of a stent that were used in our group of patients. The most common was C-guard. Next one. And the median length was 40 millimeters, median width above was 8 millimeters, and external carotid artery diameter after the surgery, the median of it was 3.18 millimeters. Next one. As I introduce you shortly to the procedure itself and the methods, it's time for the important part of the presentation, which are results. So pain was reported by the patient in both perioperative and post-operative period of time. During this and 24 hours after the procedure, only one patient complained of pain out of 26 patients. Both pain severity and pain were not associated with vessel diameter change. However, there was a statistically significant correlation between the stenosis of the internal carotid artery stenosis and the degree of pain, the severity of pain. Shortly, the more stenotic internal carotid artery was, the more severe pain was reported by the patients. The other important aspect in here is that the pain was located in many areas, and all of those areas are the main source of blood supply for those is external carotid artery. So, there is also a linear regression between the stent length and the difference in the external carotid artery diameter before and after the surgery. However, it was not statistically significant. Another outcome of our study was that the correlation between the degree of the external carotid artery and the usage of 30 and 40 millimeter stents. To sum up everything, as I said on the previous slides, symptoms were not associated with a vessel diameter change. The post-operative change in vascular diameter was also not correlated with pain severity, and there is no dependence between diameter of the stent and the vessel diameter change. Conclusions. Since I come to the end of my presentation, I'd like to make some. So there is definitely a significant positive correlation between the percentage of the internal carotid artery stenosis and the degree of pain that was reported by the patients. Another important fact is that this is a preliminary study. We are planning to continue it with a follow-up that will probably, maybe will give us more information whether covering of the external carotid artery is a shortage of blood supply can lead to the pain and other symptoms. And the last thing is gonna be that all the patients that are suffering from the non-specific craniofacial pain should undergo at least Doppler ultrasound. And that's the end. Thank you for your attention.
Thank you very much. So are there any questions for the participant?
Jeśli mogę, chciałam się spytać, jaki był wkład państwa pracy?
Okay, so we basically did everything outside the Doppler ultrasound. Yes, exactly, yes. But we were assisting to some of the surgeries. We were also gathering data. We were interviewing patients. We developed questions for them. I also did the illustration for the presentation. So yes, and what else? Yes, basically we did all of that, as I said. Yes.
Ja jeszcze zadam pytanie, jak długi był czas obserwacji po zabiegu, kiedy diagnozowaliście pacjenta?
We were interviewing patients immediately after the procedure and 24 hours after the procedure, so it was like 24 hours.
Już był tak szybki efekt, tak? Bo jak zbadać, że nie ma tego bólu, powiedzmy, który państwo tam, którym się interesowali, czy nie ma później, w późniejszym okresie?
Okay, so basically I think we can explain it this way, that during the procedure, we are inserting a balloon inside the internal carotid artery, which is causing a temporal ischemia. So it can be a source of pain. Another thing is, I know we have a collateral circulation, but arteriosclerosis is a general disease. So if it occurs on one side, it will probably occur on the other side. So it's not efficient circulation.
Thank you very much. Are there any other questions from the online jury? Don't go yet. Okay. So if not, thank you very much. Now you can go. Okay, and now, last but not least, the paper entitled Risk of Multi-Drug Resistant Staphylococcus aureus, Coverage in Dental Healthcare Workers by Dominika Komandera.
Honorable jury, dear colleagues, my name is Dominika Komandera, and I am dentistry student from Medical University of Gdańsk, and I am going to present my research project titled Risk of Multi-Drug Resistant Staphylococcus aureus, Coverage in Dental Healthcare Workers. Staphylococcus aureus is one of the most prevalent human pathogens, causing various diseases from mild skin infections to severe and life-threatening necrotizing pneumonia.
Michał, czy teraz widać prezentację?
Widać.
Wielki bracie.
Nie ma głosu. Widzi, ale nic.
Czy Państwo jury widzą prezentację?
Widać prezentację.
Widać? Widać, jak się zmienia?
Tak, teraz się zmienia.
Super, bardzo dziękuję.
Okay, so once again, Staphylococcus aureus can cause various diseases from mild skin infections to severe and life-threatening necrotizing pneumonia, infective endocarditis, and even sepsis. And Staphylococcus aureus is transmitted by droplets or directly, so there is an increased risk in dental facilities of Staphylococcus aureus transmission. And with addition of the close contact with the patient and continuous exposure to saliva and other secretions, dental staff are at higher risk of being carriers of Staphylococcus aureus than other occupational groups. Presented study included 28 dentists, 30 dental assistants, and 4 people working as registration staff, from whom nasal and hand swabs were taken and then inoculated onto Columbia agar's medium, and then identified staphylococci were inoculated onto Chapman's selective differential medium to identify mannitol positive Staphylococcus aureus strains. And the last stage of the study was to investigate drug susceptibility to selected antibiotics. And the results. From 124 specimens, we identified 27 strains of Staphylococcus aureus, and 70% of them was isolated from nasal vestibule. Dentists, dental assistants, and registration staff were carriers of Staphylococcus aureus at rates 54%, 30%, and 70% respectively, and nearly 90% of Staphylococcus aureus carriers through dentists were isolated from nasal vestibule, followed by registration staff and dental assistants. Regarding antibiotic resistance, mostly isolated Staphylococcus aureus strains were resistant to penicillin, but none of them was resistant to methicillin, so none of them presented the MRSA type of resistance. 1/3 of isolated strains were resistant to erythromycin and tetracycline, and slightly less to gentamicin. And although one strain was resistant to clindamycin, there was 8 strains which were resistant to, which presented MLSB type of resistance. It was inducible type of resistance. And there were 10 strains which presented multi-drug resistance, so they were resistant to antibiotics from at least 3 different groups. And summarizing, thanks to identifying carriers of Staphylococcus aureus in dental facilities, we can possibly assess the risk of Staphylococcus aureus infection in both dental staff and patients. And we can control the spread of multi-drug resistant Staphylococcus aureus with proper countermeasures. And thanks to analysis of antibiotic susceptibility, we can assess the possibility of eradicating carriage in dentists, dental assistants, registration staff, and also patients. And we can assess the possibility of treatment of Staphylococcus aureus infection when it is necessary. Thank you for your attention.
Thank you very much. Are there any questions for the participant?
Zapytam, dziękuję bardzo za interesujące badanie i ważne dla nas. Chciałam zapytać, czy sprawdzaliście Państwo, czy robiliście Państwo wywiad ogólny całego zespołu stomatologicznego? Czy były wśród osób badanych tylko osoby zdrowe, czy były może obciążone jakimiś chorobami ogólnoustrojowymi i może na jakichś lekach, które mogłyby obciążać, na przykład immunosupresyjnych?
Yes, the survey was yeah, we did the survey, but the results are still being analyzed. But we asked if patients were hospitalized, and they can say if they were hospitalized during their whole lives. And also we did not accept patients which presented in actual infection, like current infection, because then the results may be influenced by the infection. So yeah.
Are there any other questions for the participant? Okay, if not, thank you very much.
Także wszystkie zaplanowane na dzisiaj prezentacje zostały przedstawione. Serdecznie gratulujemy wszystkim autorom ich prezentacji, ich wkładu i wysiłku w naukę. Dziękujemy im również za udział w tej sesji stomatologii. Chcielibyśmy jeszcze raz bardzo podziękować całemu składowi jury, zarówno Państwu obecnemu tutaj dzisiaj z nami, jak i osobom obecnym online. I chcielibyśmy jeszcze zapytać, czy pani przewodnicząca komisji chciałaby dodać coś na koniec w imieniu komisji, jakieś swoje obserwacje.
Postaram się jakoś tak odwrócić, żeby do Państwa nie siedzieć plecami, bo aż mi głupio, powiem szczerze. Nie wiem, czy na następny raz się nie będzie trzeba zastanowić, żebyśmy jako komisja gdzieś albo z tyłu, albo z boku, bo naprawdę jest to dla nas troszkę niekomfortowe, siedząc tak plecami. Myślę, że się wypowiem w imieniu całej komisji. Uczciwie powiem, jesteśmy z Państwa dumni. Oprócz tego, że uczycie się, przykładacie się w większości, ale wszyscy się przykładacie, znajdujecie jeszcze czas na pracę naukową. Wszyscy wiemy, że to są początki, to są zalążki, ale skądś to się bierze? gdzieś to ziarno pada, które za ileś lat będzie kiełkować i bardzo Państwa proszę, żebyście przez całe życie pamiętali i byli z tego dumni, że kończycie kierunek lekarsko-dentystyczny i to jest nie tylko, co jest wspaniałe, leczenie i pomoc pacjentom, ale także pomoc na zasadzie badań, czyli wprowadzania nowych metod, wprowadzania nowych leków, wprowadzania nowych terapii. Nie jest to tylko odkrywanie rzeczy nowych, ale umiejętność pracy na badaniach waszych i doświadczeniu waszych poprzedników, po to, żeby cała nauka szła do przodu. A nauka polska jest naprawdę bardzo mocna. Także jeszcze raz Państwu bardzo, bardzo gratuluję i chylę czoła. Myślę, że w imieniu całej komisji.
Także dziękujemy jeszcze raz wszystkim uczestnikom i podsumowanie odbędzie się w piątek, 19 maja na tutejszej konferencji, jednak będzie ono też transmitowane na platformie YouTube, także zainteresowane osoby wynikami dzisiejszej sesji zapraszamy również do transmisji internetowej, która odbędzie się w piątek. Jeszcze nie wiadomo dokładnie o której godzinie, także informacje będą podawane na bieżąco.
Tak, i ja jeszcze chciałam dodać dla jury online. Maile poszły, mam nadzieję, że do Państwa wszystkich doszły maile z prezentacją pierwszego naszego uczestnika. Jeszcze raz bardzo przepraszamy za wszelkie problemy techniczne. Mamy nadzieję, że nam to Państwo wybaczą. No i czy chciałbyś coś jeszcze dodać, Filipie? W takim razie bardzo dziękujemy za obecność. Dziękujemy bardzo i dziękujemy za wyrozumiałość i postaramy się tylko iść w stronę bycia lepszym. Dziękuję bardzo.
Dziękuję bardzo. Dziękuję bardzo.
Dziękujemy.
Dziękujemy i żegnamy również naszą komisję online.
Dziękujemy bardzo.
Przepraszam, czy te wyniki da się wysłać, czy tylko mamy zaznaczyć i zostawić?
Właśnie też o to chciałam zapytać, bo nie mamy żadnego przycisku wyślij, akceptuj wszystko.
To w takim razie zaznaczyć i zostawić.
Okej.
Dziękujemy.
Ja już sobie sprawdzę w systemie, bo mam tutaj dostęp do systemu, także już sobie sprawdzę.
Integracja taka, no bo my się
Czy widzę Państwa karty?
nie widzujemy, na korytarzu się trudno spotkać pracy. Tak, się w ogóle dziś się u lekarza spotkaliśmy. No jeszcze właśnie u lekarza medycyny pracy spotykamy. Ja ostatnio ze studenta. Aha, lekarza medycyny na jedną godzinę byliśmy wszyscy.
Proszę o sekundkę cierpliwości jury online. Momencik.
Aha, dobrze. Czyli co, z przesyłaniem? Aha, może można tam zmieniać, bo można.
Informacja dla komisji tutaj na żywo oraz dla komisji online. Może ja tutaj się pokażę. Jeżeli Państwo zaznaczyli w systemie wszystkie punkty i wyświetliły się na zielono, to znaczy, że jest w porządku, nic Państwo nie muszą wysyłać, wszystko jest OK.
Aha. W ogóle tego nie dotykam. Tak, coś można zmienić.
W takim razie dziękuję Państwu bardzo.
Dziękuję bardzo,
i
dziękuję.
Do usłyszenia.
Do widzenia, dziękuję.
Dziękujemy.
Stańcie sobie na tle tego. No pewnie, tu.
Do widzenia.
Tak, właśnie z uczestnikami, chodźcie. Tu weź, bo tu masz dobre
Wpierw uczestnicy, tak,
Nie,
żebyście
w ogóle
wykli, bo wy
chodźcie
jesteście, że tak
prezentujący,
powiem, tak.
Zróbcie sobie...